Good morning, ladies and gentlemen. So before we begin, I would like to read the disclaimer for this session. The Department of Health, DOH, Department of Science and Technology, Philippine Council for Health Research and Development, or DOST PCHRD, and the Ateneo de Manila Institute of Philippine Culture are providing this webinar as a public service, but it is neither a legal interpretation nor a statement of DOH, DOST PCHRD, or ADMO IPC policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by the DOST, DOH, DOST PCHRD, or ADMO IPC. The views expressed by the speakers, facilitators, and viewers are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Views and opinions expressed by DOH, DOST PCHRD, or ADMO IPC employees are those of the employees and do not necessarily reflect the view of the DOH, DOST PCHRD, and ADMO IPC or any of its officials. So now, I'll turn you over to our session facilitator today, Dr. Maria Euphemia C. Yap. Dr. Yap, good morning po.
Good morning. Good morning, everyone. A hearty and warm welcome to the 18th National Health Research Forum for Action. This is the final session. We are now down to our 5th session, and the title of our session is Optimizing Financial Resources for Universal Healthcare in Times of Pandemic. I am Dr. Maria Euphemia Yap. I'm more commonly known as Marife, and I will be today's discussion facilitator. So to begin formally our program, we will begin with a short prayer, which will be followed by the Philippine National Anthem.
Let us put ourselves in the holy presence of God. Father in heaven, always merciful and giver of life, we humbly ask you bless each one of us, the speakers, program committees, guests, and participants. Guide us to make better decisions as we incorporate what we will learn throughout this activity. Thank you for the infinite blessings and countless opportunities. Lord, today as we start our activity, may we always be grateful to learn new things. Shed the light of your wisdom and bless each one, especially our speakers, as they will share their knowledge to us. Through your mercy and grace, may peace and understanding shine and dwell unto us. Almighty God, accompany each and help us concentrate for us to gain more knowledge as we listen. This we ask in your name.
Ladies and gentlemen, the Philippine National Anthem.
Amigo!
Now,
before we proceed to the presentation proper, I would like to share a brief recap of our previous sessions of this 18th National Health Research Forum for Action. We began the National Health Research Forum for Action last September 8 with the first session entitled Transparent Governance and Accountability in the Face of COVID-19. In this session, we showcased the governance indicators that were used to measure health sector performance and the studies behind the public health measures employed by the Department of Health in addressing COVID-19, which manifested transparency and evidence-based interventions, the universal healthcare principles. The next day, September 9, the second session, entitled Strengthening the Local Health System, featured the integration of local health systems into province-wide health systems and city-wide health systems. Studies on local government units, such as the UHC Primary Care Study, e-health study, and social innovation in health systems were presented. The third session, entitled Ensuring Continuity of Health Service Delivery Amidst the Public Health Emergencies, was split into two parts and conducted last October 7 and October 6 and 7. The first part focused on human resources for health and health facilities. At this session, we featured studies looking into the optimization and utilization of COVID-19 health facilities and the assessment tool used for health facilities. The second part, on the other hand, focused on special populations and primarily tackled health service delivery for these populations, such as Filipino migrants and overseas workers. Topics were also discussed related to children and elderly populations or the vulnerable groups. It showed areas of vulnerabilities and offered recommendations for these populations, especially in this time of pandemic. For participants who have just joined our forum today, we warmly welcome you to this final session of the 18th National Research Forum for Action. And so to begin, for the first part of this program this morning, we are joined by Dr. Ronald Lau. Dr. Lau is a medical officer and is currently the chief of the DOH's Preparedness Division. As Chief of Preparedness, Dr. Lau contributed to the development of health emergency and disaster risk management system in the Philippines. He is instrumental in the institutionalization of disaster risk reduction and management in health, or DRRMH, and its inclusion in the Universal Healthcare Law and the DOH policies. Dr. Lau is also a professor of public health in several medical centers and universities, particularly the University of the Philippines College of Public Health, UERM-MMC, and the Ateneo School of Medicine and Public Health. He has also authored several journals, articles, and commentaries. Dr. Lau was awarded fellowships in public health emergencies, disaster management, and health security in Australia, the United Kingdom, and the US, and has been exposed to various training internationally. He is a member of both national and international technical working groups on health emergencies and disasters, including the WHO Global Thematic Platform on health emergencies and disasters. This morning, Dr. Lau will present policy directions, present challenges, good practices, and lessons learned in implementing the National Action Plan against COVID-19. We welcome Dr. Ronald Lau.
Morning, everyone. Thanks for the opportunity to share our COVID insights in this research forum. COVID is like the rain in our UHC parade. Just when we're ready to roll out UHC, COVID-19 happened, killing its momentum. Anyway, not all is lost. We should view this pandemic not only as an adversity, but also as an opportunity to improve our healthcare system. So COVID has brought us a lot of challenges and lessons learned. In my presentation, I will share snapshots of our response milestones and ways forward by looking at our National Action Plan, or NAP, against COVID-19. I'll follow this outline. First, I'll give you a picture of our current situation, cite milestones, current policy directions, and review the NAP. Second, I'll discuss some challenges, present some good practices, and share lessons learned. Finally, I want to venture on some ways forward and tie in the important role of research, not only supporting COVID response, but also in facilitating UHC implementation. You can see here as of November 24, the numbers of our cases, recoveries, deaths. So generally at the national level, after 8 months, we are seeing a downward trend of cases. But we have to interpret this with caution. In some regions, cases are picking up because of some localized transmissions. But by and large, our health system capacity in terms of prevention, detection, isolation, and treatment has substantially improved. So with the help of everyone, so thanks to you, we already did a lot of good things, but we need to sustain this. We still need to expect and prepare for the worst. As the situation is fluid and there are still uncertainties, the virus, immune response, people's behavior, sustainability of our interventions, the availability of a safe and effective vaccine, we cannot put our guards down. In terms of policy, we have shifted from total risk avoidance to risk management. We can't anymore afford to do strict lockdowns that hurt the economy and impact the health system in the long run. We can't also gamble opening the economy without putting in place some measures, our minimum health standards. So it's not anymore an argument between health and economy, which is more important. They are both important. We need to do effective health risk management when we continue opening up the economy. We need to implement the NAP to bring down cases to very low levels, if not zero. But aside from reducing cases, a key priority now is protecting the vulnerables and improving case management to decrease morbidity and mortality, not only from COVID, but from other health issues as well. At the moment, we are transitioning from response to recovery. When we enhance our capacities for COVID response, we are mindful that these are also the same efforts needed to prepare for the next pandemic, the next emerging infectious disease, or other health threats for that matter. We believe this should inform UHC. This is an overview of our National Action Plan, our operational framework in addressing COVID, comprised of different strategies that fall under prevention, detection, isolation, treatment, reintegration, and mainstreaming in the new normal. The framework did not change much, but with the evolving situation, we had to shift strategies. We had to adapt. All of these were based on science and available evidence. They informed the policies that were implemented in the different phases. For instance, in phase 1, from March to June, it was all about saving lives, suppressing the pandemic through higher quarantine levels. In phase 2, from July to September, when we lower the quarantine levels, It was about shoring up the economy. Phase 3, from October to December of this year till first quarter of next year, we want to manage health better and learn to live with the virus and lay down our plans for vaccination. We can say this NAP has been useful as a response tool, as a way to collaborate with partners, and as an instrument for bringing out good results. These are challenges that we faced. Some we're still facing. Uncertainties of COVID that lead to changes in policy. Wearing of masks, change of transmission from droplets to aerosols, what tests to do, evidence on school closures, herd immunity, reinfection, vaccine availability, long COVID, etc. Coordination. We're a country of many islands with evolved health system, a bigger private sector, with many agencies coming from different disciplines. So policy should be unified and coherent, but development, dissemination, and implementation have been challenges. Operational issues and logistical concerns, lack of testing capacities, not enough contact tracers, health workers to man our quarantine facilities and hospitals, lack of PPEs and other supplies, a lack of dedicated COVID beds, even depleted funds, data management, non-functional surveillance systems, reporting system is not accurate, not robust, not real-time, data sharing concerns, poorly developed M&A systems, poor translation of data into information for action, lack of technical capacities. Communication and people engagement. Managing the infodemic, promoting health literacy, reaching out to all Filipinos using different media, platforms, behavioral interventions, people engagement to get their cooperation, build trust. And finally, concurrent disasters, other health issues, non-COVID, etc. So typhoons, Rolly to Ulysses. So these complicate our pandemic response and compound existing issues of our health system. These are multifaceted challenges that need to be managed. Research on this is much warranted. So take your pick. On a positive note, I would like to highlight a shining example of one good practice. It is the DOH collaboration with our NDRRMC for a whole-of-society approach to addressing health threats. First, through governance, leadership, and coordination, we're able to tap a mechanism that allows us to interface with different agencies and partners to have a unified approach to management because of the incident command system and our link through the Emergency Operations Center. Second, through all hazards risk management. The role of health in other hazards and the roles of our partner agencies in health issues must be clear. So an all hazards approach can facilitate joint risk assessments, planning, training, exercises, and even response. Lastly, this can be applied to how we handle current emergencies like Rolly and Ulysses on top of COVID. So with this mechanism, we're able to do camp management with public health measures like physical distancing, implementation of our minimum public health standards, for example. Also, access to lifelines is assured if and when we need this. For example, after typhoons Rolly and Ulysses, we're able to count upon our partners in restoring telecoms, transporting our logistics, repairing our damaged health facilities, relief and support for our affected health workers, all because we are connected with the NDRRMC and our other partner agencies. So this existing mechanism, which was built over the years, is a game changer, not only in terms of response to COVID and other health threats. So this should be sustained, documented, and shared. In a gist, these are our lessons learned. 1, science is useful, but it keeps on changing, so policy must be adaptive. 2, communication is critical for risk communication, health promotion, and trust building, and even behavioral modification. 3, whole of society approach is a requirement The DOH cannot do it alone. No one country can do it alone either. 4, local government units and communities are the real frontliners. They know their own needs, but ownership is needed. So national government just has to empower and support them. 5, investments in disaster management for all hazards is crucial. Pandemics, infectious diseases, natural disasters, other health issues, communicable and non-communicable, addressing health inequities, protecting the vulnerable, strengthening the building blocks of our health system. This must be sustained, built into the system so it becomes stronger and more responsive to the needs of the times, the new normal. So let's all be cognizant of all these lessons. And this time, let's really learn from all of this. These are things being done now. We are finalizing the NAP3 to guide us through to recovery and mainstreaming in the new normal. This will also include our vaccine roadmap and other strategies to respond to emerging realities. This will have a multi-sectoral strategy map with indicators to make sure all of us are singing the same tune. We're also streamlining the response structure to simplify coordination mechanisms and ensure accountability for results. We are putting increased emphasis on recovery and UHC implementation for health system development. And finally, we are deliberate in doing more people-centered approaches, more LGU-led strategies, and more national mechanisms to enable and empower our partners and stakeholders. We have to sustain our previous gains and make sure we do a better and more responsive implementation of NAP Phase 3. In our fight against COVID, the call for community resilience has been made. Kaligtasang pangkalusugan laban sa corona sa kamay ng komunidad, or 5K. Resilience must be built from the ground up. Primary care activities that will build resilience should be supported. Disaster and health systems should be built. National government support through policies, capacity building, technical assistance should be continued. In the time of COVID, we need to document our experiences. We need to do research so we can use this in our programs and policies. As final message, research should guide us on what we do in the time of COVID. Research can also tell us how our COVID experience can be used to advance UHC. But most importantly, research can influence governance and leadership. When this happens, we know we can be more confident in saying, we will be able to put this pandemic under control. We are going to thrive in the new normal, and we are going to transform our health system for the future the UHC way. So let's continue working together towards our common goal and let the light of research shine upon us. Mabuhay po tayong lahat at maraming salamat.
Thank you very much, Dr. Ronald Lau, for your presentation. Ladies and gentlemen, I would just like to correct the session title for this 5th session of the 18th National Health Research Forum. The title of this session is COVID-19, Lessons and Ways Forward. Apologies for the mistake of giving the title of session 4. And so to move on, I would first like to request Dr. Lau to turn off his camera for a moment, and we will see Dr. Lau again in the question and answer segment. And for our participants, we encourage you, if you have any questions, please send them in our chat box. To proceed to our next presentation, we are joined by Dr. Alethea de Guzman to give us a background on current initiatives undertaken and the respective challenges encountered in her presentation entitled COVID-19 Surveillance and Quick Action Unit Data Management Systems. Dr. de Guzman is currently with the Department of Health as a medical specialist 4, and she served as a Development Management Officer 5 from 2014 to 2016. Dr. De Guzman has a master's degree in community health management from the Ateneo de Manila University Graduate School of Business. Good morning and welcome to the forum, Dr. Alethea De Guzman.
Dr. De Guzman, ma'am, kindly check your microphone, please. Dr. De Guzman, naka-mute pa po ata. Ma'am, could you kindly refresh po your page? I think we're having connection problems. Kindly refresh lang po yung page natin.
Am I being heard now, Paulo?
Yes, ma'am. Now you're clear.
Okay. There was some connection problem. I apologize.
Okay lang, ma'am. Thank you.
I apologize. There was some connection problem. So again, good morning. I'd like to start off this presentation first with these three key messages. That first, we are seeing a decrease in our national level indicators as to disease transmission, especially in the recent months. But there are still areas, specific regions, provinces, and cities where we are seeing an increase, and these areas require close attention. For us to be able to monitor these trends, we need a consistent and reliable source of data and information, so we not just see the trend of cases, but also monitor operational performance of surveillance, contact tracing, isolation, quarantine, and even the adherence to minimum health standards. And lastly, the data quality issues require investments, not just by the government, but multiple sectors, so that we build our epidemiology and surveillance capacities across all levels. And when we talk about building capacities, it includes adequate and competent personnel who are equipped with the needed tools so that they can efficiently implement their processes. Next slide, please. Next.
Hold on lang, ma'am. Saglit lang po.
I'll pause. So, let me go through the next one. So as of November 24, we're already reporting 421,722 confirmed COVID. Apologies.
This one, ma'am, is the correct one.
Yes. Okay. Yeah. Thank you very much. So as of November 24, we're already reporting 421,722 confirmed cases. If you look on the lower left corner, the percentage of active cases or those who are currently admitted or isolated and assumed to be infectious has already decreased to 6%. Around July, this was as high as 60%. And among those who are active, around 8% has severe or critical disease. With a decrease in our active cases, we're also seeing a concomitant increase in the proportion who have already recovered. This is already at almost 92% as of that date. Our deaths had the case fatality rate, or the proportion of cases who became deaths, has plateaued at around 1.9%. But below that, I showed the difference between the case fatalities among those aged 49 years and below and those aged 50 years and above. And I will go through that in more detail later. Next slide, please. This is what we call an epidemic curve, where we plot the cases based on when they got sick. And it shows a continuous downward trend nationally. The blue bars are cases coming from NCR. And as you'll note, the national epidemic curve is greatly influenced by the movement of our NCR epidemic curve. And while we're seeing this dramatic decrease for the national capital region, there are also decreases in other regions, but it is not as marked as NCR. And we are seeing decreases in regions outside of NCR, such as those located in the Visayas and in the Mindanao regions, as well as our northern Luzon regions. Next slide, please. This is a distribution of cases as to whether they're active, recovered, deaths, and their case fatality rate. While the National Capital Region, Calabarzon, and Central Luzon registered the most number of cases and the most number of active cases, the highest case fatality rates were actually in other regions. Central Visayas has the highest case fatality rate, followed by Caraga and then by Zamboanga Peninsula. Next, please. And since we're talking about mortalities, in the same way that our cases peaked around August, this is the same for our deaths. No? It peaked around a week or two after our cases peaked. And while we see also a downward trend, it is not as fast or as significant as our case data. And most of the cases came from NCR at the start. These are the blue bars. And then we had the surge of fatalities from the Central Visayas region, followed by deaths coming from the National Capital Region. But much like the cases decreasing in NCR, deaths already decreased, but additional deaths or most of the deaths are already coming from regions outside of Metro Manila. Next slide, please. This is a table showing the distribution of cases and deaths and how, while most cases were actually among the less than 50 years old, the deaths, or 80% of deaths, were actually among those aged 50 and above. And as such, you'll see a marked increase in the case fatality rate at 3% among those reaching 50 years to as high as 18.7% among those aged 80 years and above. This puts emphasis on the need to enhance prevention measures, especially among our elderlies and among the vulnerable groups. Next slide, please. This graph shows the sources of infection that we've analyzed as of November 21. The graph shows that while these are the possible exposures of the cases that we have identified, and that at the start of the epidemic, there were numerous infections among our healthcare workers, and these are the dark blue bars. And this decreased with clearer infection prevention and control protocols, as well as the increased availability of PPEs. The yellow bars were returning overseas Filipinos, and crucial to preventing transmission from this group was border screening, as well as immediate quarantine upon arrival in the Philippines. Also, once we eased community quarantines in June, we saw infection among local travelers and individuals from Metro Manila returning to their permanent homes in other provinces. These are the brown bars. And what was notable were the light blue bars, or the cases who had no known exposure to a confirmed case or to a setting with detected confirmed cases. The proportion of cases with unknown exposure has increased over the recent months. Next slide, please. So what has been the challenges? Our numbers show that how COVID-19 tested our own preparedness and response plans. It shone light into areas which we had to strengthen and invest more, such as ensuring that our health system will not be overwhelmed. It should be a health system that will provide quality care, not just to our COVID-19 cases, but also ensure continuity of essential services such as immunization, reproductive health, and management of non-COVID-19 conditions. Our devolved system also made effective coordination and alignment of national, regional, and local responses more complex. The pandemic also instilled a lot of uncertainty because of the limited information available, as well as how swiftly the pandemic was evolving. And this created an increased demand for innovation and flexibility from us. Next slide, please. But despite all of these challenges at the start of the pandemic, we have now gained a lot of ground, and we did this as a team. Next, please. A major gain was how COVID-19 fast-tracked our goal of attaining universal health care, especially for the provision of population-based epidemiology and surveillance services. Our data quality initiatives covers first, governance through the Interagency Task Force, or IATF, which is a policy-making body for the COVID-19 response. Establishing the COVID-19 Surveillance and Quick Action Unit, which is directly accountable to the Secretary of Health in ensuring quality data needed for action, and adopting policies and conducting capacity building for epidemiology, surveillance, and response. We also now have close to real-time information through new and interoperable operation systems and more efficient data processing that enables us to generate daily numbers in hours when it previously actually took us days. No? Data analytics included establishing technical working groups involving experts from public and private agencies and organizations, automated dashboards and platforms that provide us more time to focus on data interpretation rather than data generation, and improvements in our strategic communications with the goal of providing meaningful information and relevant messages to the public. All of these were made possible because of linkages with other government agencies, the private sector, and our international partners, and most especially the network or our family of epidemiology and surveillance units. In the next slides, I will briefly show some of these data analysis platforms. Next slide, please. FASTER is a project recently donated to the Department of Health. It is a platform where we visualize case and health system capacities. It also includes COVID-19 time series projections, as well as computations for reproduction number using EpiEsteem and EpiNow. Next slide, please. The DOH COVID-19 tracker has several uses. It links to the public to a data drop where an anonymized case line list is uploaded daily and can be downloaded by the public for independent analysis. The tracker also allows the user to generate case data as to place and time and visualize them as shown here. Next slide, please. Internally, we have dashboards that generate line lists with data quality issues and needing further validation, as well as to monitor our data quality indicators on completeness, validity, timeliness, and the number of duplicates. Next slide. So there's still a lot of big challenges ahead. No? Functionality and competency of our epidemiology and surveillance units have to be swiftly achieved. We have experts and scientists who have and can contribute to our body of knowledge, but we need to unify them despite differing agenda. And lastly, this pandemic made our decision makers realize and appreciate the value of data. Now, I think it is up to us to create an opportunity to widen and sustain our relevance and the appreciation for the vital role that quality data play in this pandemic response. With that, thank you and a good day to all.
Thank you, Dr. Thea, for your discussion. And now I'd like to request Dr. Lau to join us as we now open the floor for questions from our participants. We have been collating your questions that have been raised by our participants in the chat box. And so let's begin right into the questions. The first question is directed to Dr. Lau. Is there a coherence of policies across different government agencies in terms of responding to COVID-19? Dr. Lau?
Dr. Lau, I think your microphone po is on mute. Oh, naputol si Dr. Lau. Dr. Yap.
Sige, while Dr. Lau is fixing his logistical concerns, maybe I can pose this question. I'm not sure, but maybe Thea can answer this. Are there measures and mitigations that our COVID-19 response has taken to ensure that the frontliners' well-being and workforce are sustained? Sorry, Thea, but maybe you can contribute whilst Dr. Lau is still fixing his mic. So are there measures, would you know this, to mitigate COVID-19 response for the frontliners' well-being and workforce? And can this be sustained throughout?
Yes. So thank you po, Dr. Marife. Yes, as shown in the presentation I gave, there were really a lot of healthcare work infections when we started, no? But however, the proportion of those getting ill among our health workers have steadily decreased. And this can be attributed to, number one, really clear guidelines on how our health workers can protect themselves from practices of IPC, as well as the availability, ensuring that there is adequate number of personal protection equipment for them. No? And there are also clear guidelines. There were a lot of questions who should go on quarantine, who should have themselves tested. These are all now well stated in our policy so that our health workers don't know just how to protect themselves, but how to be managed when and if they become exposed, or how will they be managed if they become confirmed cases themselves. Over.
Thank you, Dr. Thea. So Dr. Lau, I'll just pick up from the question that was raised for which Dr. Thea gave us a response. But can I ask you also about this? Are there measures and mitigations that our COVID-19 response takes to ensure that the frontliners' well-being and workforce are sustained throughout? That's one of the first questions, Dr. Lau.
Dr. Lau, your audio po is not coming through.
I think there's still some technical difficulty with Dr. Lau. JP?
Yes, ma'am. Dr. Lau, you can, I'm sorry, but you can try answering po through the chat box and then we can read it for you po.
Okay, while we're waiting for that, and since Dr. Thea is with us, you did mention, Dr. Thea, about challenges, no? In particular, I think you had mentioned something related to working with local government units. Can you just please expound a bit as to why this has been a challenge? And second, why this is very important? And I also allude to your emphasis on the need to build capacity on epidemiology and surveillance at all levels. I ask this because I know a bit of what this is, what the challenge has been, but maybe you can tell us more about this and maybe emphasize how truly important it is to capacitate our resus and pesus and why they're such an important contributor to the conversation. Thea.
Thank you, Doc Marife. So if as we all know, the Department of Health receive a lot of flack of how poor their data quality is. And I think what the public and what we need to realize is that because our health system is devolved, we depend a lot on how functional our local government units are and our health facilities are in collecting data and reporting them. And thus the need that when you talk about functionality, while the Epidemiology Bureau or our regional epidemiology and surveillance units can perform all of these functions, this has to be also as functional as with our local epidemiology and surveillance units. What we've always emphasized is that the response should be LGU-led. That's why the national government has created policies that are general enough for them to be flexible, because we believe that being on the ground, our LGUs have the best perspective as to how they can best respond. But I think one of the consistent challenges is appreciation by LGUs of how important data is. Oftentimes, they look at data or our surveillance data as just counting numbers. But I think with this pandemic, they realize that it's actually their data which will dictate and will tell them how well they're doing or not doing. And it is the one telling us how we should improve our response. So one of the major, and even our Secretary of Health made this a mandate, that there should be competency. There should be a standardized competency across all levels, especially our local epidemiology and surveillance units. Thus, the invitation to, the Epidemiology Bureau conducts trainings on epi and surveillance, and really look forward to conducting all of these for all of our LGUs and even our partners, such as our hospitals and other organizations.
Okay, thank you, Thea. I'm not seeing Dr. Lau yet, and I guess can I just pursue this conversation with? Okay, Dr. Lau is in. Dr. Lau, are you okay now? Can we just? You're speaking, but we still cannot hear you. Oh, sorry. JP, how do we do this?
Dr. Yap, we have a response from Dr. Lau in the chat box. Dr. Lau, we apologize, but he says here, policy coherence has been a key challenge, but there is policy coherence now because of better engagement with stakeholders and partners. Ayan. Thank you, Dr. Lau.
Dr. Lau, the other question that you may wish to reply is with regards to the COVID-19 vaccine. What are the timelines that we can expect, and is there a rollout plan for this? So if you could give us a response to that. And the other question is, you did say already the coherence of policies across different government organizations. So in the meantime, while Dr. Lau is looking through that, Thea, just one more question, if possible. I know that in the early, or maybe in the months of April, May, and June, it was very stormy in terms of reporting, right? That's why there had to be a change in how, so this was when the fresh and late cases terminologies came in, etc. And finally, thank God, we were able to at least settle that down a bit. Would you be able to tell us what sorts of tipping points happened? Or as far as I know, the reporting now is quite on time. It's quite real time, as you said. I know you mentioned this already, but maybe you can just tell us in your mind and in your observation, since you've been at this from the very beginning, what would you say is the tipping point here, which I think will also highlight among the lessons that you learned and also mentioned by Dr. Lau as one of the important harvests in this COVID-19 challenge? Thea?
I think Doc Marifer, the greatest tipping point was decision makers realizing they need to invest in data, in reporting, in epidemiology and surveillance. They were angry that we're not providing quality data. But from the start, we've been harping on how we need to strengthen capacities at the LGUs and the hospitals. But to be quite frank, we were met with a lot of why would we need to put people, why do we need to invest in information systems, the old systems were working. But I think when they realized that we need to put people in LGUs, we need to put people who will collect and analyze data in hospitals and in laboratories, as well as that shift. It's really difficult to shift from a paper to a digital information system. Even now, we're still meeting a lot of challenges, but I think most of our stakeholders, our decision makers, have come to appreciate that and are committed to improving and investing in improving not just the capacities, but also how do we more efficiently collect this information. We have COVID Kaya as a central repository now, but we had our partners helping us develop additional information systems and data collection tools, which make it easier for our laboratories and their disease reporting units to collect and report data. And we also have partners, such as Faster and our thinking machines, which help us increase the efficiency of how we analyze, of how we clean our data and visualize them so that it's more digestible and it's more relevant to the people, both public and our decision makers. It's something more meaningful for them.
Okay, thank you very much. Thank you very much, Thea. Dr. Lau, we really apologize for this technical glitch that we have. I guess we can still share any responses that you may have to the questions that were raised through the chat box. And I think there will still be some opportunity to respond if there are other questions. But
Dr. Yap,
yes, JP, go
let me
ahead.
just read Dr. Lau's response. No, sabi po niya, there's already a vaccine roadmap looking into many aspects until distribution. There are some good vaccine candidates already, but it's hard to say when it will be available specifically in the country. But all steps are being done to fast track it, and it is a key priority now for NAP3. Yan. Thank you, Dr. Lau.
Okay, thank you very much. So thank you, Dr. Ronald Lau, Dr. Alethea de Guzman, for sharing your expertise with us. And we'd like to encourage and invite our participants to continue to send their questions. Unfortunately, we're already going to go into a 5-minute break before we move to the next session. And so if you have your questions, kindly email them to the email address NHRFA2020@gmail.com. I think you will be able to access that email address in the chat box, NHRFA2020@gmail.com. So once again, thank you very much, Dr. Ron, Dr. Thea, for your contribution and your expertise. And now we are going to go on a 5-minute break, and then we will resume to the next session. Thank you very much.
Patuloy pa rin ang laban natin sa COVID-19. And together, we can beat the solution.
B. Bawal walang mask.
I. Isanitize sa mga kamay. Iwas hawak sa mga bagay.
D. Dumistansya ng 1 metro.
A. Alamin ang totoong impormasyon tungkol sa COVID-19.
Protektahan natin ang sarili at mga mahal sa buhay.
Beat the solution sa COVID-19.
Magandang araw sa lahat. Patuloy pa rin ang laban sa COVID-19. Sa tulong ng mga tamang impormasyon, kakayanin nating supuin ang kontrabida.
Correct ka dyan, Doc Meng. Kaya ngayon, alamin nating mga bida kung ano-ano ang mga dapat gawin kung kayo ay may nararamdamang sintomas at kung sa tingin nyo ay nahawaan kayo ng sakit na COVID-19.
Simple lang yan, Doc Sam. 3 bagay lang ang kailangan tandaan. Step 1. Mag-isolate o bumukod kung ikaw ay may sintomas ng COVID-19 at kung ikaw ay isang close contact at o may relevant travel history.
I-ready ang mga phone at screenshot ito para malaman anuman kung ikaw ba ay isang close contact at o may relevant travel history. Kailangan mong malaman at tandaan ang mga sumusunod kung ikaw ay mag-a-isolate ng sarili. Una, kailangan ay manatili kang mag-isa sa isang kwarto. Ikalawa, iwasan ang pakikihalubilo sa mga kasama sa bahay.
Ikatlo, magsuot ng face mask at kung maaari ay surgical o medical face mask. Ikaapat, lalong mas okay kung gagamit ka ng face shield.
Ikalima, maghugas lagi ng kamay gamit ang sabon at tubig sa loob ng 20 seconds o gumamit ng alcohol-based sanitizer. Ika-anim, i-disinfect ang mga bagay-bagay na nahawakan.
At ikapito, ibukod ang mga plato, kutara at tinidor mula sa iba. Matapos mag-isolate o bumukod, ito naman ang ikalawang hakbang. Step 2. Kailangan mo nang tumawag sa inyong Barangay Health Emergency Response Team o BHERT. Ang inyong BHERT ang bahala sa inyong referral at testing para sa COVID-19.
Habang hinihintay ang nararapat na referral para sa testing o admission, ay ihanda na ang mga sumusunod. Mga dokumento ng pagkakakilanlan tulad ng official IDs, PhilHealth IDs at iba pa. Extra cash din kung kakailanganin.
Mga damit at toiletries kung sakaling ma-admit sa isang TTMF o ospital. Cellphone at iba pang kailangan na gadgets.
Huwag kalimutan ang alcohol, hand sanitizer at syempre, face mask.
At panghuli, maintenance na gamot kung meron. Tandaan na kailangan mo pa rin sundin ang mga tips sa pag-self-isolate habang hinahanda ang lahat ng mga ito.
Upang maibsan naman ang sintomas mo, maaari mo ring gawin ang mga sumusunod.
Una, uminom ng paracetamol kada 4 na oras kung umabot sa 37.8 degrees Celsius o pataas ang inyong temperatura.
Ikalawa, uminom na madaming tubig, sariwang fruit juice kung mayroon.
Maaari ring uminom ng maligamgam na tsaa o gumamit ng throat lozenges para sa pangangati o pananakit ng lalamunan. At panghuli, magpahinga at matulog.
Tandaan na hindi ito gamot sa COVID-19. Kung naayos na ng inyong BHERT ang iyong referral, doon na tayo sa panghuling hakbang. Step 3, ang pagpapatest at pagpapa-admit sa isang TTMF o ospital.
Sa hakbang na ito ay mangongolekta na ng specimen para sa testing. Base sa iyong sintomas ay maaari ka ring i-refer para sa admission sa isang TTMF para sa mild symptoms. O di naman kaya ay sa isang ospital para sa moderate, severe symptoms.
O mga bida, huwag kalimutan ang 3 steps na ito ha.
Step 1.
I-isolate ang sarili.
Step 2.
Tumawag sa BHERT upang ipagbigay alam ang iyong kondisyon.
At Step 3.
Sumailalim sa testing at manatili sa isang TTMF o ospital.
Tandaan, sa panahon ng pandemya, bida ang may alam.
Patuloy pa rin ang laban natin sa COVID-19. And together, we can beat the solution.
B. Bawal walang mask.
I. Isanitize sa mga kamay. Iwas hawak sa mga bagay.
C. Kumistansya ng 1 metro.
A. Alamin ang totoong impormasyon tungkol sa COVID-19.
Protektahan natin ang sarili at mga mahal sa buhay.
BIDA, be the solution sa COVID-19.
Thank you very much, ladies and gentlemen. I hope you're all still with us here during the break. We will now have Dr. Yap. Dr. Yap, we're back.
Thank you. Welcome once again to our 5th session of the 18th National Health Research Forum for Action. This session's theme is COVID-19, Lessons and Ways Forward. We are now proceeding to the presentation of studies related to COVID-19 response. Each presentation is allotted 20 minutes, after which we have invited some reactors to give some of their insights and raise a few points also for 10 minutes. The rest of the 10 minutes will be allotted for the question and answer portion, where we entertain questions from our participants that will be collated from the chat box. For the first study, we are joined by Dr. Maria Regina Justina E. Estuar. Dr. Estuar is currently the Executive Director of the Ateneo Center for Computing, Competency, and Research, or ACCCRE. She has a master's degree in computer science from the Ateneo de Manila University, and Dr. Estuar holds a PhD in social psychology from the same university. Dr. Estuar is an active member of the Psychological Association of the Philippines, the Computing Society of the Philippines, and the American Psychological Association. Today, Dr. Estuar will present to us the feasibility analysis on syndromic surveillance using spatial temporal epidemiological modeling, or as what Dr. Thea mentioned in her talk, FASSTER, FASSSPER, and its application during this COVID-19 pandemic for modeling and monitoring of the outbreak, and as to how this innovation transformed data into meaningful information for decision-making through projections. Good morning and welcome to the webinar, Dr. Regina Estuar.
Good morning to everyone. Can I get a cue if I can be heard?
Yes, Dr. Estuar, you are loud and clear po, and your video is also looking good. Thank you, ma'am.
Okay, thank you. Good morning, everyone. Okay, next slide, please. Thank you. FASTER stands for Feasibility Analysis of Syndromic Surveillance using Spatial Temporal Epidemiological Modeler for early detection of diseases. No? This project was a vision that we started with in 2016 when we realized that there was a need to develop an ICT-based disease surveillance platform that would provide geospatial analysis and prediction modeling, as well as provide scenario-based projections based on different situations and intervening. At the bottom, you will see the different types of models that we were using in 2016, as well as the diseases that we were working on, localizing dengue, measles, and typhoid. And then we also experimented in extracting data from different sources, such as news, PIDS-R, which is the official disease surveillance platform of DOH, social media, and also electronic medical records. And what we wanted to produce was a web-based and mobile-based platform for disease surveillance and monitoring. Next slide, please. For the next 3 years after 2016, we continued to develop the 3 localized models for dengue, for measles, and for typhoid. And then we went on to developing the dashboard itself, and then implemented it in our pilot region 6. No? On our final year, 2019, we were about to turn over the project to the Department of Health and the Epidemiology Bureau, and COVID came. No? So next slide, please. You will see that the original FASTER dashboard had syndromic surveillance. It also had a mobile application where our birds can report symptoms that they have discovered or reported by our constituents. The constituents also can report through SMS the symptoms that they are feeling. Next slide, please. Last March 23, we formalized the project again, faster, but now specifically for use of our LGUs. The framework that you see now shows us the actual data sources that we are using for FASTER. Specifically, we are using COVID Kaya as our main source of information. And then we are also using other data collection tools provided by the government or the Department of Health. All this information is stored in a data warehouse where the data is formatted to be fed into the different models that we have now in FASTER. And it is really meant to be used by our information consumers, which are increasing as we move from day to day. Next slide, please. Okay, so this is another way of viewing FASTER. No? So from the data source, we move the data to the data warehouse. And then from the data warehouse, we do back-end computations. And then we now display them in something that is meaningful to our intended users. Next slide, please. Okay, now when you look at FASTER, FASTER is on the rightmost side of the ICT architecture of COVID. No? So there are several systems that are now into play as we develop the models for the dashboard. Now, on the leftmost side, you will see our data collection tools from citizen reports or self-screening, also from our contact tracing apps and LGU apps. We also have data coming from PhilHealth and from our laboratories, and also fed into our main information system. And all these things are used in aggregated form to develop the different models and analytical tools in FASTER. Next slide, please. Allow me to show you some of the different dashboards. So there's a lot of features already in FASTER since we started last March. So first, the screen is your case statistics, where you will see the demographic distribution, where meaningful information is used to profile by age groups or by comorbidities or by gender or sex. The dashboard allows us to select down to the LGU level before we run the different statistics and the models. Next slide, please. Okay, this is an example of the RT where we provide two ways of computing the time-varying reproduction number. So one is EPI-ESTIM and another one is EPI-NOW. One has a 14-day delay to balance the data. The other one has a projection capability. Next slide, please. Okay, this is the most recent addition in the dashboard. So as we moved from month to month, the dashboard was not built in isolation of our government agencies. So we have been guided initially by the sub-DWG and data analytics, and then our IATF, and now guided by the EPI Bureau and the team of DOCTEA on quality assurance. So this latest page provides a one-stop shop for our LGUs on what they need to see when they need to decide on the type of quarantine that is needed for a particular place. Next slide, please. So it's very comprehensive. If you scroll to the right, you will see the different columns providing all the information needed by the LGU. And the most important indicator, I think, in the most recent IATF is the average daily attack rate and the growth rate. Next slide, please. There. Next slide, please. Okay, one of the more important tools, of course, of FASTER, and the first and primary feature of FASTER is the projection model. I now present to you the SEIR model that has been designed for the Philippine COVID-19 pandemic. It has 6 compartments, SEI, A for infectious asymptomatic, and IS for infectious symptomatic. confirmed for the C, and recovered. Now, this mathematical model is translated into code and visualized in FASTER. Next slide, please. So this is what it looks like when it is now visualized. No? There is an option for our users to select a scenario for the type of community quarantine, the type of health capacity, and also do tracing, meaning do comparative analysis if you change the values. Next slide, please. And then once projections are made for the peak, we also provide projections for the health capacity requirements for the hospital. Next slide, please. For the testing. Next slide, please. And for the community requirements, community capacity requirements. Next slide, please. As we moved from month to month, we realized that there are other things that we needed to put in the dashboard. So we also have now our health capacity for the hospital, current capacities of our hospital to determine if the area is at risk, meaning there are so many cases confined in the hospitals and there is no space. So that might be an indicator of a possible lockdown, temporary lockdown. Excuse me. Next slide, please. Together with our partners from the Autumn Group in Monash University, we also developed a dashboard for age-structured modeling. So we follow the same SEIR model, but the projections here are used using age groups. Next slide, please. We also have a lot of spatial analysis provided for our users. Our users are from top down and bottom up. So we have our IATF members. We also have our members from the different agencies. We also have our users down to at the LGU level. So these three maps show us examples or features of spatial analysis that we have in FASTER, where we do cluster analysis or we do correlation, spatial autocorrelation, and we also do average daily attack rate shown in maps. Next slide, please. Okay, aside from health indicators, we also provide socioeconomic risk indicators with data coming from DTI, NEDA, and DSWD. Next slide, please. And we also have security indicators, risk indicators. This is updated every 2 weeks by our PNP. Next slide, please. There you will see an example of the risk level and also the listing of major and minor crimes depending on the type of quarantine. Next slide, please. Okay, the most recent addition to FASTER would be the socioeconomic portal, which we are still building. This is now funded by together original funding agencies, PCHRD, but this next phase is funded by UNDP, where we are trying to develop a socioeconomic model for recovery. Next slide, please. Next slide, please. Okay, some statistics. So in general, there is an increase in usage of the tools that we have been developing for the Department of Health. Tanod Contra COVID is a partner system of FASTER. This is for self-reporting of symptoms. Next slide, please. So our usage reports have shown us that there is an increase and there's a decline at some point. So there's also some problems with additional people who need to do this 24/7, and I think this has been addressed already in most recent reports. Next slide, please. And also the FASTER usage statistics, which mostly are being used by our government agencies and local government units. Next slide, please. So this is an example of the rollout statistics. What we're trying to do here is to see the usage in response to the performance of the LGU, and hopefully we will have better dashboards to show the effectiveness of the dashboards in providing meaningful information to our LGUs. Next slide, please. Okay, last contribution, which we're really working hard on, is the contact tracing page, where FASTER is the recipient of several contact tracing applications. And we are building the social network analysis models for every contact tracing app. Next slide, please. So these are just some of the prototype of the dashboards that we are building for contact tracing. Next slide, please. There. So this is an example of a dual network social network analysis, where you can view not only person to person, but also location and events. Next slide, please. Next slide, please. Okay, for the lessons learned, first, data science. Data science deals with imperfect data. Models and analytics aim to represent reality, but can never be a full replacement of reality. Real data is really imperfect. There will always be variances. During this pandemic, where stability of systems are still being established, FASTER was able to address the need of the Department of Health for an operational dashboard that served to provide baseline information for decision-making at various levels. So it is not perfect, but we believe that it provided sufficient information for our government agencies to make informed decisions. Next is multidisciplinary approach. Data science is not a single discipline, but best practiced by a multidisciplinary team. We started with a team of 25 people coming from different fields: math, computer science, information systems, epidemiology, and to name a few. Third is that multi-agency approach is needed. As researchers, we needed to go down from our ivory tower, down the hill, and to listen to our agencies, listen to what it is that they need, understand their problem, and wear their hats before we provide our solution. So the approach was not providing a solution and then looking for a problem, but then really identifying what is needed by our agencies and providing them with the information that they need. So it was a 24/7 service that we provided to our government. And as we will continue to be faced with data challenges, we will continue to collect more information that needs to be cleaned in relation to newer forms of testing, vaccination, and contact tracing. I believe that we have had a good experience for the past 6 months. It has taught us very much already how to move forward in relation to data science. Thank you and good morning.
Maraming salamat, Dr. Rina Estuar. Indeed, a very fulsome work that the team is doing with FASTER and its contribution to the work for data management and data analytics for COVID-19. So now we will proceed with a reaction and additional insight and inputs. Our reactor is Dr. Eileen T. Riel Espina. Dr. Riel Espina is representing the Health Professional Alliance Against COVID-19, or HPAAC. Concurrently, Dr. Eileen serves as a consultant for health system strengthening through health human resource development for the province of Northern Samar. She is also a consultant for CARE Philippines, a pilot program for the prevention and management of non-communicable diseases within internally displaced persons, communities, and health systems affected by war in Marawi. Dr. Espina is also a life member of the World Organization of Family Doctors, or WONCA, a steering committee member of the ASEAN Region Primary Care Network, and a national director of both the Philippine Academy of Family Physicians and the Foundation of Family Medicine Educators. Maayong buntag, welcome to the forum, Doc Eileen Riel Espina.
Dr. Espina, excuse me ma'am, kindly check po yung microphone natin. Nakamute po ata. Hold on ma'am. Oops.
Is that okay now?
Yes, Doc. That's perfect po. And your video also looks really good. Thank you, ma'am.
Okay. Thank you. So, magandang umaga po sa ating lahat. And I would like to say, technology has indeed been demonstrated to be a very useful and value-adding tool in the COVID-19 response, as demonstrated and documented by experiences from all over the world. Thus, I would like to thank the organizers of the 18th National Health Research Forum for Action for choosing this important topic to be part of this year's conference. Thank you too for your kind invitation to HPAC, which paved the way for my participation today. That being said, I would like to congratulate Dr. Estuar and her team of experts from the various collaborating agencies and organizations for their laudable efforts in the development of FASTER and for that very comprehensive and mind-boggling presentation. I concur with conviction that FASTER, if used maximally, can really provide evidence-based forecasting for possible cases and scenarios on the spread of COVID-19. It can really guide local and regional leaders to contextualize and make the response more efficient and effective. As emphasized by Jeremy Lim, a professor of public health in the National University of Singapore, as published in the Singapore Times, our ability to harness information communication technology is one of the important B's of the COVID-19 pandemic response. Actionable information, and may I repeat, information derived from data analytics as provided by technology like FASTER, and not just mere data gathering or counting numbers as emphasized earlier by Dr. Teya, is what would allow policymakers and implementers to understand the pandemic at the national, regional, and local leaders. Information would allow them to assess the effects of the different measures they have put in place and would guide them in determining what works and what needs to be improved. Unfortunately, the use of digital technology for data gathering and analytics in our country has been fraught with quite a number of challenges. People questioned if its use would really safeguard our people from the pandemic. A lot were skeptical if it can really control the spread and break the chain of transmission. Furthermore, people were also asking, will it not promote a greater social divide between those who are tech-savvy and has digital connectivity from those who aren't and who have none? Then, questions on human rights, digital rights, and our rights to privacy were also raised, and rightfully so, if I may opine. The developers were questioned. Are they acting in a transparent manner when they introduce this technology to us? Conflicts of interest were also raised. A way to address these challenges, actually, is for government to make sure that there is no false dichotomy existing between our desire to protect the health citizens and their human rights through digital technology. The biggest lesson learned from the COVID-19 response, as mentioned several times this morning, is that you cannot have information without good quality data. So the challenges that I've mentioned earlier are essential so that people would be willing to share their data. Other lessons that are also that we were able to note in the course of these 9 months are as follows. Digital technology is not the end. It's not like a magic pill or a silver bullet that if we use it, everything will be a-okay. It is not the end all and be all of the response, but rather it is a means to an end. It is a tool. It should be a value-adding tool. It has also shown that with proper and efficient use of digital technology, it would allow us to maintain access to care and basic services, like in the case of telemedicine and telehealth. It also made us realize that we can, as mentioned by Dr. Ron Lau, turn this adversity into opportunity. Thus, the Healthcare Professionals Alliance Against COVID, or HPAC, after a participatory consultative process, made these recommendations to the President and his Cabinet on October 12 on how the IATF and NTF can better harness ICT for COVID response. What is very crucial is collaboration. Thus, at the moment, HPAC, together with IATF and NTF, are now working with a group of stakeholders in coming up with an interoperability platform that would allow for data sharing, which we hope can feed into FASTER to allow for data analytics that would produce knowledge and information for the COVID response. Lastly, I would like to recommend that FASTER should not be kept a secret. There should be a massive information and dissemination campaign to spread the word about it so that more and more LGUs would access it and use this very important resource in the COVID response. Thank you and good morning.
Maraming salamat, daghang salamat, Dr. Eileen, for your very insightful inputs related to FASTER and the contributions driven by the HPAC. So now we will move on to the question and answer portion of this forum. And we'd like to invite back, I see her now, Dr. Rina, to answer some of the questions. So let me just go right into the questions that have been posted in the chat box, Dr. Rina, and I'll begin with the first question. Are the data gathered from commercial businesses, that is, body temperatures and other information required before entering their premises, useful for the COVID-19 database and contact tracing?
The answer is yes. No, these are called digital logbooks. Right now, they are not yet incorporated in our ecosystem, but I believe this is one information that will be very, very relevant, no, to improve our analytics. That is what is missing, no, yung the daily real-time monitoring in non-health places, no, to be included in the analytics. Yes, we agree that it's very important.
Ma'am,
Dr. Eileen,
yes,
of course, please go ahead.
In the last slide that I shown, that was actually scope in our meeting, which we had just yesterday. Dr. Astuar, we will be inviting you once again. We did had an initial meeting already about this, and among the data capture systems that we have scoped include those in business establishments as well as in workplaces. Because we are aware that DOLE, for example, has the WAIR and the daily health declarations. Then, yung mga QR code po na ginagamit ngayon sa mga tindahan, wherein we are made to log in whenever we visit a particular store or restaurant. That is what we're trying to scope in. If you look at the framework that I have presented. Dun po sa data capture systems, we're trying to fit it all in. And so we're trying, it's still a debate whether we're going to use an ESB or an API framework. But definitely, we will be inviting you po. Kasi sinama po namin talaga in the lower portion. Faster is really there because we believe that the analytics that you're doing should really be complemented by the data gathering, by the data capture systems that are all over the place. Para na po silang mga kabute, no? They're mushrooming every day. Parang bawat LGU may sariling ginagawa. So, paano po natin kukunin lahat yon, Ma'am Marife, no? Para we will have it all in one space. Yun po.
Maraming salamat. Thank you for that input as well, Doc Eileen. Yes, I agree with you. Para na silang mga kabute at nagdadagdag lang sa kalituhan sa pagkangayon kung hindi i-consolidate. So thank you very much for these efforts. Moving on to the next question. Do we have ongoing COVID-19 socio-economic risk assessments or researches that are specially focused on the middle income and below poverty populations?
Yes, no. In one of my slides, we already showed you, no, parang a sneak peek of what we are developing, no. So for prior to the 6-month end of the first phase of the project, we already had some socioeconomic indicators, but these were very static indicators, no. But syempre, things have changed, no, over time, and then the different types of quarantines have affected already our economy, our security, no. So for the next phase, UNDP has graciously agreed to fund the next stage of the project so that we will be able to develop a socioeconomic model which incorporates, no, our health indicators. So meron na po tayong dinidevelop and then this Saturday actually, no, magkakasama po sila Doc Eileen. I think we're going to meet, no, as a team to understand better, no, how these socioeconomic indicators will be relevant for recovery.
Thank you. Doc Eileen, would you like to say something regarding this question?
Actually po, very early in the COVID response, the Population Commission already have a GMC with, I think, DILG and DOH with regards to the economic indicators, specifically on households. They tried to identify households with vulnerable population, yung elderly, tapos yung mga solo parent households. And they, our USEC po si Jappy Perez was saying na very important po talaga yung socio-economic indicators natin because this household should really be, sila po yung dapat tutukan because pag sila po yung natamaan ng COVID, mas kailangan po nila ng mas maigting na suporta mula sa gobyerno dahil sila po yung nasa vulnerable population groups.
Thank you very much. Very well said. I know that also in the conversation to the transition to the new normal, the indicators that are being looked at are the impacts already to the socio-economic groups kasi para bang, so what? Kung do we open the economy? Do we start going face-to-face, etc.? And so these are really issues at the very core, kumbaga right at the gut. So yes, very timely, and we await whatever data or information can be released from this in the next weeks or so. Moving on, third question. It is observed that the national COVID-19 cases trend is largely dependent on the data trend of NCR, suggesting that NCR has relatively more lax safety measures than other cities, areas of the country. How do we address this? Maybe Doc Eileen, Doc Rina?
Baka Doc Eileen yan, ano? Kasi
Doc Eileen muna, and then Doc Rina if you have something to add. Go ahead, Doc Eileen.
Parang napaka-judgmental naman. I would like to believe po na yung initial po talaga natin na ground zero for COVID was really NCR. Kasi ito po talaga yung entry point natin. Ito yung biggest entry point to the outside world. And importation po talaga yung nangyari, no? And then also, the congestion in urban areas is also a consideration. The population is also a consideration. Malaki ho talaga yung population. And our country being archipelagic, it really took some time bago nakalabas ang virus to other parts of the country. And by the time na nakarating po yung virus to the other islands, they were already able to set up significant or more stringent border controls. And also, they learned from the lessons that we learned the hard way in NCR. So medyo mas there was time. The lockdown that happened in March brought us enough time for the other parts in the country to learn and put up the defenses. So I don't want to sound like pero parang NCR had to suffer so that the rest of the country would learn from the lessons that NCR had to learn with difficulty. Yun lang ho ang masasabi ko.
Yeah. Salamat. Thank you, Doc Eileen. Doc Rina, would you like to add?
Well, from a data science standpoint, ganun din po, no? The value of the big numbers in NCR helped us really prepare our models for the other regions, no? So always ang basis namin is NCR. When it's not a good fit, no, we check everything based on NCR, based on the different cities in NCR. Pag na-adjust na po namin yan, when we run it in the other regions, it's better, no? So again po, no, the numbers that we have, no, for NCR, sad to say, no, sila yung pinakamataas, but it really helped in the data science part also.
Okay. Thank you very much. So, yeah, tama naman si Doc Eileen. Hindi naman siguro lack safety measures. Ang kataon lang talaga na andito ang marami at saka nandito yung lahat ng mga factors that facilitate transmission. But anyway, so thank you for that. And yes, you are both right that I think the NCR experience taught many lessons in many ways. So moving on to our last question, because we have to close this session already. Are there public platforms where we can access prediction models on future COVID-19 cases and other relevant information? Doc Rina?
Marami naman pong public models, no? FASTER is not the only dashboard that the government is using. In fact, different agencies have their preferred, no, dashboards when they do their policies, no? Ang meron po tayo ng public dashboard ng DOH mismo. Meron din po ang UP National Resilience Institute, no? Meron din silang mga projection models doon. I'm not aware of the others, no? But I think the main difference lang po is that FASTER was really designed to be agency and LGU based, no? Yun talaga yung design niya kasi down to the LGU level, granular level po ang design niya. But there are publicly available dashboards for projections po.
Thank you. Doc Eileen, would you like to contribute?
I agree with Doc Rina. Marami hong available. So, ang maganda ho dito is how we will be using the different na platforms or dashboards. Kasi one dashboard may have information na wala doon sa dashboard na ginagamit natin, so we can use it to complement. That's why in our work with different LGUs, we introduce COVID Kaya, FASTER, and a lot of other things, and we tell them that you can actually pick out the information that you need that are available in those specific dashboards and use it to complement what you have in order to have a, let's like casting a wider net so that you will catch more fish and have a more complete idea or picture of what is really happening.
Okay. Very well said and very much connected to the message of Doc Thea. We need to empower our local epidemiology units, and that's important because, as Doc Rina said, it's the LGU who will be able to do something about it. Public access to dashboards, if not well understood, can lead to more confusion, which we do not want. And so we laud the effort also of HPAC trying to bring all of this together, for at the end, it is the citizenry who needs to be able to understand in order to be able to act well. So with that, we thank you very much, Dr. Maria Regina Estuar, Dr. Eileen Riel Espina, for your valuable contribution for this session, and we invite you to stay on as we move on to our next part of the forum with the study of Dr. Alejandria. Maraming salamat sa inyong dalawa.
Thank you, ma'am.
Thank you.
So, moving on now for our second study, our presenter, we are joined by Dr. Marisa Alejandria. Doc Isa, or Dr. Alejandria, is the president of the Philippine Society for Microbiology and Infectious Diseases, or PSMID, and is a co-chair of the Philippine Society for Microbiology and Infectious Diseases Committee on Standards of Care. She is an Associate Dean for Research in the UP College of Medicine and is also the Head of Research and Implementation Development Office and a professor in the Department of Clinical Epidemiology in the University of the Philippines. Today, Dr. Alejandria will present the processes and methodology behind the PSMID COVID-19 treatment guidelines development, which shall provide insights on the future of treatment guidelines, especially addressing unprecedented public health emergencies of this nature. Magandang umaga po and welcome to the webinar, Dr. Isa Alejandria.
Thank you, Professor Marife. And thank you to the organizers for this opportunity to share with you our experience in developing the COVID-19 CPG. So magandang umaga po sa lahat ng mga nakikinig. Is my audio okay? Can you hear me?
Yes, Doc. Okay po yung audio niyo, Doc. Thank you po.
Yeah. Okay. So why do we need a CPG and how do we develop one in a pandemic setting? So the global pandemic of COVID-19 has challenged all sectors of the global system and directly hit is our health system having to deal with this novel virus. Born out of fear, the frantic search for interventions for COVID-19 has led to a toxic legacy of poor quality research, media hype, lax regulatory oversight, and vicious partisanship, such that we see now that the pandemic science is seemingly out of control. Sensationalized and premature release of news on effective treatments continue to hound our media. So we continue to see premature press release on effective treatments for COVID-19, and Wikipedia, for instance, has also listed more than 100 proposed interventions for treatment or cure for prevention of COVID-19. The data on the global literature on coronavirus also shows that there is an exponential increase in the number of literature. As of today, more than 120,000 studies have been indexed in the database. So that's about one study every 3 minutes. Okay. And this has led to an infodemic, infodemic of information, misinformation, and disinformation, such that we now have to flatten not just the pandemic curve, but the infodemic curve. So how do we beat this infodemic? Okay. So as healthcare providers, we have the ethical obligation to provide optimum care, but more importantly, we should not be doing more harm with new interventions. So how then do we optimize care? So this is where now clinical practice guidelines have to come in. So what are clinical practice guidelines? So clinical practice guidelines are statements which include recommendations intended to optimize care and that are informed by a systematic review of evidence and careful assessment of the benefits and harms of alternative care options. Okay. So clinical practice guidelines, if properly done properly disseminated and implemented, can improve the quality of healthcare by reducing variations in clinical practice and ensuring efficient use of limited resources. So, flashback, what have we done in this pandemic with regards to providing guidance to our healthcare providers? So as early as January, when the novel coronavirus was declared as a public health emergency of international concern, we have come up with several triage algorithms and interim clinical management guidance for our frontliners and healthcare providers. So, I'm having problems moving the slide. Okay. So, for instance, for the triage algorithms, as I mentioned, as early as January, we've come up with these one-page algorithms to guide our frontliners in screening suspects, patients who are, or persons who are suspected to have COVID-19. So these algorithms are designed to assess exposure history and help our frontliners decide on whether they will be quarantined or admitted into the healthcare facilities. And these algorithms quickly evolved as the travel restriction policies change. So by March, we have 7 versions already. We had 7 versions of the algorithm. And then we also complemented this algorithm with this unified algorithms. But before this, actually there are missing slides. Before the unified COVID-19 algorithms, we had clinical management guidelines. We developed the interim clinical management guidelines in February as we prepared for the potential increase in number of cases. As you know, we started having community transmission towards the second half of March. But in February, we developed the initial guidance already for clinicians on how to diagnose, manage COVID-19 and what infection prevention and control measures should be instituted. So by March, when we had the lockdown because of the community transmission already, we updated the February guideline. So we had a March version because at that time also, that was when there were a lot of interventions being publicized, such as hydroxychloroquine, lopinavir, ritonavir, azithromycin as being effective for COVID-19. So we quickly developed the guidelines on what interventions should be used during that time. And by April, we realized that it's not just the hospital that needs guidelines. So the primary care setting also needs guidance. And our volunteer organizations, aside from PSMID, PCP, the Philippine Society of Public Health Physicians, Philippine Society of General Internal Medicine, they all volunteered to come up with algorithms derived from the guidelines to help our frontliners also in the community and in the level 1, level 2 facilities. So we expanded the guidelines from hospital care to primary care, PPE used by healthcare workers, and guidelines on return to work. Okay. Next, please. Yeah, okay. And then towards May, when we started seeing a decline in the number of cases, when the number of cases were stabilizing and somewhat declining, there was now a clamor from clinicians on how they would be able to go back to their clinics safely and start seeing patients whose care has also been compromised because of the lockdown all clinics and elective cases had to be deferred, or they were not prioritized. So there was now a clamor. So we came up with the guidelines on how to safely open the clinics and then how to safely do elective surgeries, give chemotherapy. So that was in May. Next, please. Okay. And in July, we also updated the guidelines for clinical management, because by that time, results of clinical trials were coming out. So we, again, needed to review the evidence and provide guidance to our clinicians. And it was only in November that we were able to update the algorithms and expand to include patient navigation, patient reintegration, and emergency services. Okay, so those are the guidance, the guidelines, algorithms that we were able to develop for the past 9 months. Okay, so how were we able to do those guidance and algorithms? So what enabled us to carry out this development of CPGs in a rapid pace? Okay, so it was through the spirit of volunteerism. So my students in clinical epi, colleagues in clinical epidemiology, during the lockdown, they volunteered to review the evidence, synthesize the evidence of the interventions that the society has compiled, and gave it out to them, the questions that need to be reviewed. And we use the rapid evidence review process for synthesizing the evidence. And these reviews were posted in the website of the Philippine Society for Microbiology and Infectious Diseases. Okay. So in doing the rapid review, so we identified the questions, did literature search, appraised the evidence, and synthesized this evidence. And in a period of 2 to 3 months, our rapid reviewers, or whom we call our rappers, volunteer rappers, were able to come up with 67 rapid reviews. And these rapid reviews were the ones that we use. So the COVID CPG task force of PISMID used these rapid reviews in updating the recommendations for diagnosis and treatment. Next, please. Okay. So what enabled us, essentially, is that it was providential, I would say, that in 2019, project with DOH Ahead, wherein we trained more than 100 participants on the process of developing clinical practice guidelines, including how to appraise the literature. And this provided us a critical mass of evidence reviewers that we were able to tap during this pandemic. And they willingly volunteered to appraise the evidence for us. So the spirit of volunteerism, flexibility, agility at this time of the pandemic, when I actually called for help from them to help us assess the evidence, enabled us to come up with the interim guidance and to be able to update them as needed. Okay, now let's move to the challenges that we've encountered. So as the pandemic progressed and the number of cases increased, the literature also continued to increase exponentially. As you've seen, in the early part of the pandemic, it was easy to come up with the algorithms, the guidance, because there was very little that we knew about the virus. So it's mostly like there's insufficient evidence. But as the pandemic progressed and as the literature evolved, it became more difficult to synthesize the evidence. And as you've seen, the gap of updating the interval, no, by which we were able to update actually increased. No? So from monthly, it's like every 3 months, then to 4 months, 5 months. So the challenge is because of this rapidly evolving evidence. So next, please. Okay. So this figure here shows you the network. No, this is an evidence network of clinical trials of the top 15 interventions in April. Okay, so in April was the peak of trials that was registered. By April, there were about 500 trials already that have been registered, and by October 2000, more than 2,000 clinical trials have been registered and 134 clinical trials published. Okay. Next, please. Next, please. Okay, I'm missing one slide. So the challenges that we encountered were the rapid evolution of the evidence, the volume of evidence, the quality of the evidence, and then the urgency of the need to be able to synthesize and come up with the recommendations. It is also a challenge to disseminate and implement the most recent or updated guideline because, as you know, the evidence evolves, no? And then the other challenge is sustaining our reviewers. So our reviewers also need to go back to their work. So there are competing interests and responsibilities such that we had difficulty updating the rapid reviews. If you go to the website now, our rapid reviews are dated May. So they urgently need to be updated. So moving forward, we applied for a grant to PCHRD and the Department of Health to develop a living COVID-19 CPG. So we propose to adapt a living CPG model to be able to update the existing guidelines in a structured way and with funding to be able to support our reviewers. So next, please. So what's a living COVID-19 CPG model? Okay, so the left-hand side is the usual CPG model. No? So from guideline preparation, evidence synthesis, coming up with the recommendations and disseminating it. So this is the base CPG. The living component is the one on the right side. What consists of the living component? No? So the living component is wherein we identify recommendations that will be switched to a living status and perform regular surveillance of the literature on these recommendations. So our living status for a recommendation is decided on if it's a priority for decision making, and we think that it's most likely that new evidence will come up, then we tag that recommendation as a living status recommendation, as a living recommendation. And if a recommendation is tagged as living, regular surveillance of the literature, either weekly, monthly, needs to be done by our evidence reviewers, and then they will appraise the evidence and present the output to a smaller subset of the consensus panel. So we have 3 committees in the CPG that needs to be maintained. So the steering committee, which oversees the questions that need to be included in the guideline, so the interventions, and then we have our evidence review experts who synthesize the evidence, and the consensus panel who vets on the recommendations based on the evidence summaries. Okay. Next, please. Okay. So essentially, a living practice guideline is an optimization of the usual guideline development process to allow updating of individual recommendations as soon as relevant new evidence becomes available. In the usual process of a CPG, of a known disease, it usually takes a year, no? The fastest is a year to come up with a guideline. So in a situation where we have a new disease or a new virus, the more practical model is really a living practice guideline so that you are able to update as soon as evidence becomes available. And the guideline needs to have a living system, is based on living systematic review, which is continually updated also as evidence becomes available. And then, as I mentioned, we identify which recommendation will be tagged as a living recommendation. No? So based on priority or importance of the question and probability of having new evidence coming out soon. Okay, so next, please. Okay, so what are the elements necessary to produce a living CPG? So we need a living systematic review, living evidence profile, living evidence or decision table, a living guidance panel, peer review process, publication and dissemination, and a living budget. So to run this living CPG, we need a dedicated steering committee, evidence review experts, and consensus panel that will focus on the living recommendations and will have the commitment to be flexible and agile to respond to the need to synthesize the evidence and update the recommendations. So next, please. Okay. So while we do have international recommendations, recommendations from WHO, CDC, USNIH, we still need to review these recommendations, whether we are going to adopt in toto or we need to localize the recommendations based on our setting, based on our resources. Okay. So CPGs don't happen overnight, and for a new disease, it's a living mode that we think is the more practical, feasible way to address the rapidly evolving evidence. And we thank the DOH AHEAD program and DOST PCHRD for funding the update of the current CPGs that we have. So we have now started meeting with our steering committee and started forming our evidence review experts and consensus panel so that we can quickly move into updating, especially the more important, the critical recommendations in the CPG on diagnosis and treatment interventions. So that's it. Thank you very much for your attention.
Maraming salamat. Thank you very much, Dr. Isa Alejandria. Before I call on our panel reactor, just to want to express in behalf of the Filipino people and many of us who have benefited very much from the quick action of the release of the CPGs of PISMID and who have guided a lot of the action of the early months of COVID, and we know will continuously guide us. So we will discuss some more about that after our reactor will give her input. So let me now call on our reactor, Dr. Jihan Maher Mohamed Amin El Abdelkawi. She is a medical officer 4 in the Department of Health. Dr. Abdelkawi holds a master's degree in management, major in hospital administration from the Philippine Christian University. Friends, please let us welcome Dr. Gigi Abdelkawi to render her reaction for the second study. Welcome to the webinar, Dr. Gigi.
Thank you very much. Next slide. The coronavirus disease 2019, or the COVID-19 pandemic, has challenged the global health security, as well as the readiness and responsiveness of the global community to collectively address an emerging infectious disease health threat. The pandemic has also had an impact on all aspects of life, including our social behaviors, our politics, the economy, and the environment. It has affected all regions of the world at all geographic levels, as well as communities, households, and individuals. Next slide. The Philippine healthcare system is devolved since 1992. The responsibility of providing basic healthcare services for the people was handed down to the local governments, specifically municipalities and cities. All citizens are entitled to free healthcare under the Philippine Health Insurance Corporation, or the PhilHealth. The indigent patients have access through the Malasakit Assistance Program in public and select private hospitals in the Philippines, and the no-balance billing policy enables the vulnerable sectors of the program, such as the poor and the elderly, to pay no more in excess of their PhilHealth coverage when confined in government health facilities. The Philippine healthcare system, struggling to meet the demands of a population of 108 million Filipinos using the curative model, was shifting to primary care in order to provide universal health care to all Filipinos when the pandemic hit the country. The government of the Philippines embraced a whole-of-society approach from the onset of the COVID-19 pandemic in its response strategy in line with the WHO recommendations. IATF were replicated at regional and provincial levels and have allowed for a localized adaptation of existing guidelines throughout the country, specifically in the flexible adoption of travel restrictions and quarantine measures based on the current status of the outbreak in a specific geographic area. Successful collaboration with the private sector and non-government partners helped to align government guidelines. This is an achievement in itself for the country, as it is difficult to transform institutions, professions, and infrastructures that have long been established. Change is not something people normally adapt to in a short period of time. Next slide. On behalf of the Disease Prevention and Control Bureau of the Department of Health, I would like to take this opportunity to express my sincerest gratitude to the Philippine Society of Microbiology and Infectious Disease, most especially to Dr. Alejandria and her team for being at the forefront of battling the COVID-19 pandemic. The development of the PISMID clinical practice guidelines has guided the country in drafting several policies on COVID-19. 13 administrative orders, 137 department circular, 239 department memorandum, 401 department orders, and 25 memorandum circular. Unprecedented number of issuances in response to an unprecedented global pandemic. Next slide. For the DOH, among the notable issuances were the strengthening of hospital infection prevention and control measures to prevent the spread of novel coronavirus. Next slide. Guidelines on the standards of airborne infection isolation room and conversion of private room and/or wards into temporary isolation rooms for the management of patients under investigation for the 2019 novel coronavirus. Next slide. Guidelines on the return to workplace, guidelines on risk exposure assessment of healthcare workers, guidelines on the disposal and shipment of the remains of confirmed cases of 2019 novel coronavirus acute respiratory disease. Next slide. And many others that are notable. Next slide. The CPG had a role to play even in the development of the national COVID-19 strategy refresh. Vince Lombardi once said, "Individual commitment to a group effort, that is what makes a teamwork company work, a society work, a civilization work. And we have proven to have done that in the Philippines with the assistance of members of our society, both the national, the local health, and the private sector. As mentioned by Dr. Law of the Department of Health, Health Emergency Management Bureau, and Dr. Alethea de Guzman of the Department of Health Epidemiology Bureau earlier, with the ever-evolving scientific evidence, next slide, on COVID-19, so will the approaches to managing the disease. We look forward to the updated version of the clinical practice guidelines and for the support of the Philippine Society of Microbiology and Infectious Disease in the future endeavors of the Department of Health. Thank you.
Maraming salamat. Thank you very much, Dr. Abdel Kawi. Very well said. In fact, that this has truly been unprecedented in terms of how our Department of Health has responded with all the numerous circulars and guidelines. So we now move on to open the floor for our question and answer segment. We'd like to invite back Dr. Isa Alejandria to join us for this portion. Dr. Isa, are you back so we can fire off with our questions? So let me now begin with the questions. A question is, are the clinical practice guidelines developed for COVID-19 also being cascaded to the LGUs and rural health units?
Perhaps I could answer that.
Go ahead, ma'am. Dr. Jihan, please.
Yes, so there is a system in the Department of Health wherein if new guidelines are developed through our development management officers and through our health promotion officers in the regional level, they cascade these issuances to our local government units as they are the liaison officers of the DOH at the regional level.
Thank you.
Yeah.
Doc Isa, maybe you can also tell us how the CPGs are cascaded from PISMID onwards. Go ahead, Doc Isa.
That is actually one of the challenge during this pandemic because we had to quickly develop, and then we are also the frontliners. So we are for the public side, so we relied on DOH to cascade it, and then for the private side, so we have our website, we post it on our website, and then we have our Viber groups which we spread through our different members and practitioners, our colleagues, in other societies also. So in our respective networks, it is really just through our networks, social networks, that we are able to cascade the guidelines. So it was not really a formal dissemination that we are able to do. So that was really a challenge.
Yeah, and to pursue that, Doc Isa, are you therefore saying that it would be better if there is a more structured, systematic way of disseminating or cascading these guidelines?
Mm-hmm. Yeah, it would be helpful if the channel, the dissemination channels can be mobilized. Because right now, for us, it's our website. We have our website, and then Facebook, Twitter, all the social media, and then of course we also give it to DOH to help us. So essentially, we'll have to probably. Yes, when we come up with this COVID-19, the living CPG model now, so we'll talk about also how to disseminate, cascade in a more efficient way that we are able to access or provide, reach all the practitioners.
Yeah. Thank you very much, Doc Isa. And needless to say, even as these guidelines have been made by specialists like you and your colleagues, these are really meant for general practitioners and health professionals. Is that correct?
Yeah. For the this update, so we're expanding, no? So our steering committee includes also our Philippine Academy of Family Practitioners, also support our public health physicians. So, and the scope will also cover not just hospital care, but primary care and prevention and control in the community setting as well as the hospital setting. And we have DOH on board, of course, also, so that because we need to get feedback also to make sure that from the stakeholders that the important interventions are covered in the CPG across all settings. So that's what we plan to do.
Okay. Thank you very much. And that's a very good segue to our second question, which is, do we also provide trainings to further the integration of CPGs to our frontliners and first responders? Maybe Doc Jihan and then Doc Isa.
So actually, if you may visit the DOH Academy website. So we have videos there that have corresponding CPDs if you attend. Those are on healthcare worker infection, risk of exposure, waste disposal, all of the major topics that have been covered by the PCHRD guidelines are actually there. So we have one for our healthcare workers that are in the hospital setting. We have for the community setting, and we also have for our BHWs. So they can access those videos for additional learning. So that is one way, one of the ways that we've tried to disseminate the policies or the guidelines at a level that we could ensure that all would see them.
Okay. Thank you, Doc.
Posted in the website. Yes.
Thank you, Doc Jihan. Doc Isa, anything to add to that?
With regards to training on how to implement the guidelines.
Yeah, to integrate the CPGs, yes, for frontliners and first responders.
Okay. Yeah. Again, that's a challenge as well, no, in a pandemic setting, no. So, I think the most efficient way really is those in the front lines, not the hospitals, because the guidelines are meant to be guidelines, no. So they will actually have to be adapted also in the local setting, no. So they might have to improvise, as come up with their own algorithms, as modify the algorithms based on their setting, because the guideline will not actually be able to cover all scenarios, no. So we put in the principles there and then examples. But if there are circumstances in your facility that is not probably covered by the guideline, and then that is when you need to make some tweaks, no. So in terms of integrating it into your system, okay. So that is something that we have to explain also, no, to practitioners, especially those in the front lines, no, that there are rooms for flexibility, no, that it's not like this is it, this is the law, no. Because we cannot cover all, so there has to be flexibility also in the implementation part of the guideline.
Yeah, very, very well said, Doc Isa. There is just a correlation, related question. I'm not sure if you care to respond, but it's, do we already have standard protocol or guideline for dead body management for those who died due to COVID-19 that are being cascaded also to the LGUs? Is this part?
Yeah, we have a part there on the how to care for bodies, no, for the dead. So there's a section there in the guideline, and actually DOH has an issuance on that also based on the guidelines.
Okay, so thank you for that. And maybe one last question. I think this is for Doc Jihan, but of course, Doc Isa, please respond as well. How does the DOH ensure cohesive and sustainable partnerships with the private sector to manage the COVID-19 pandemic? And what are the challenges that the DOH faces in forging partnerships with the private sector? Doc Jihan?
So in terms of forging relationships with the private sector, we try our best to be proactive. So we partner with other government agencies such as your DOLE, your DTI, the SWD, DepEd. So that's one way that we approach the proactive partnership, the private sector, since some members of the private sector fall under their jurisdiction. So that's one approach. Another one is through our local government units that encompass these members. The third approach is through the direct what do you call this? Directly meeting the members. So say for example, we conduct webinars, we conduct trainings for free. We try to coordinate with our regional officers to try to contact the most vulnerable members or the most at risk of exposure. So we've done this during the ECQ and the GCQ, and also with companies that have a large number of employees. So that's also one way. And you see, this pandemic has really strengthened our out-of-the-box solutions in trying to reach the public. So online platforms are also one of the most efficient ways, but as mentioned by Dr. Alejandria, the proliferation of infodemiology has also hampered the way we connect with the public, because infodemiology really affects the way that health policies are delivered. So that is the challenge. Yes.
Yeah. Thank you, Doc Jian. And I'm going to give Doc Isa the last word, precisely because, in a sense, the PISMID and the other professional organizations are private organizations. And I think unprecedented is the work and partnership with the DOH, and maybe some suggestions from your end as to how to sustain the robustness of this partnership. So, Doc Isa, you have the last word here.
Yeah. Well, I just like to say, so in the initial part of the pandemic, it was just really piecemeal, at that time, because especially like January, Feb, that we were working on the algorithms, and then eventually, as the pandemic progressed, we realized that it cannot be piecemeal alone, and it was. I'm very happy and to say that the HPAC, the Health Professionals Alliance against COVID-19, really helped all the professional societies to come together, collaborate in this control against in this fight against COVID-19. And through HPAC, which has more than 160 organizations, plus the steering committee, we were able to get audience with the Department of Health, with the IATF, to further refine the strategies that we are implementing to control COVID-19. So here we see really how collaboration among private sector, and then the private sector collaborating with and all the LGUs especially also. So this really showed how we can work together to control this pandemic, which really requires a whole of society approach, as we've seen the extent of the impact of the pandemic. Yes, we really need to strengthen the what we have started, and I guess it's really through constant communication, maintaining an open line. So, like for this initiative, the COVID-19 Living CPG, I really asked the help of the Department of Health and PCHRD to help us sustain the initiative. And likewise, we provide some co-funding. So really, it's collaboration, and we need to build on these collaborations and that we have already forged among us.
Thank you very much. Very well said, Dr. Marisa Alejandria. Again, just to reiterate what I said earlier, I know that among the most tired and the most stressed of the practitioners in this COVID-19 are the infectious disease doctors, as well as the many health professionals who've had to take on treating patients, making the guidelines, helping in the policies, attending the meetings, and toughing it out there with the different policy makers to push for what is needed and what is important. So again, our deepest gratitude to all of you, and under your leadership, Dr. Isa, it has really moved a lot. So again, many thanks, Dr. Marisa Alejandria of PISMID, Dr. Jihan Maher Mohamed, Amin Abdelkawi of the Department of Health, for sharing your expertise with us today. So we thank you very much for that. And so with this, we are reaching the tail end of our fifth session of the National Health Research Forum for Action. And as we wrap up our session, we would like now, Dr. Isa, Dr. Jihan, you can now sign off from this and join in this listening to the closing remarks. So with this, I would like now to call on Dr. Gloria Nenita Velasco, Doc May, as we know her, to deliver the closing remarks in behalf of the Department of Health. Doc May, as I know her, is the OIC Chief Health Research Division of the Health Policy Development and Planning Bureau. Doc May has a Master of Science in Public Health with orientation in Health Systems Management and Policy, a diploma in Clinical Epidemiology, and of course, she is a Doctor of Medicine. Dr. Gloria Nenita Velasco, please, for your closing remarks.
Good morning, everyone. On behalf of the Department of Health, Undersecretary Mario Villaverde and Director Francis Rose Elgo Mamaril, I wish to acknowledge first and foremost the efforts of the organizing team of this year's National Health Research Forum for Action. From our division, Technical Lead Renee Lynn Cabanero Gasgonia and Francis Karen Nuestro. From the Philippine Council for Health Research and Development, Clarissa Reyes and Ana Sharon Itulid, Grace Ann Senon. And from the PCHRD PhilHealth team, Mark Enrico Hasta and Maidi Marco. From the Ateneo Turo team, Dr. Dennis Batangan, JP Dalupang, Haraya Marikit Mendoza, and Queen Ann Tayam, and Jane Acera. We also wish to thank our co-session organizers from the DOH and PhilHealth for their time and effort. From the DOH, Undersecretary Mirna Cabotaje, Assistant Secretary Kenneth Ronquillo, Directors Maria Soledad Antonio, Napoleon Arevalo, Irma Asuncion, Gloria Balboa, Beverly Lorraine Ho, Rachel Tolentino, Maria Teresa Vera, and Faith Alberto. Drs. Ruth Politico and Alethea de Guzman, Ms. Francis Priscilla Cuevas, and their technical staff that provided additional support. From PhilHealth, President and CEO, Attorney Dante Heran, Acting Executive Vice President and Chief Operating Officer, Narisa Santiago, and Acting Senior Manager, Dr. Mel Santillan. We also wish to thank all the session moderators, presenters, and reactors, all 51 of them, for participating in the forum in their respective roles and contributing to the refinement of the programs for our 5 sessions. And finally, we thank you, the participants, for your sustained interest and participation. From its inception, the National Health Research Forum for Action has served as a platform for knowledge dissemination and policy translation, where researchers, policymakers, academicians, and technical experts converge to discuss research evidence and their use in policymaking. Through the forum, we aim to showcase both research, such as those implemented under our Advancing Health Through Evidence Assisted Decisions with Health Policy and Systems Research Program, or AHEAD HPSR, and other research and evidence generation efforts, and examples of evidence use in decision-making and policy development. Early on in the pandemic, there was a global-wide dearth of evidence on COVID-19 that challenged policymakers, decision makers, and implementers. But several months on, the collective evidence generated has been astonishing and inspiring in spite of the challenges to researchers all over the world. However, know that at present, there are more than 200 entries and counting in our COVID-19 local evidence database that includes planned, ongoing, and completed research, evidence reviews, models and projections, and research articles by our local research community, a number of which have been used to inform policymaking and decision-making. We hope that this interest in producing, appraising, and making sense of research evidence is equally sustained, not only to further guide our response to and recovery from the COVID-19 pandemic, but also to guide our implementation of the reforms needed to achieve universal health care. This particular forum, while it may be the 18th run, was a first for us in a number of ways, partly because of circumstance, but largely due to the collective effort of the organizing team, session organizers, moderators, presenters, and reactors. This is the first online version of the forum, the first time we explicitly aimed to co-organize sessions with other DOH units, the first time we've doubled the number of forum participants, and the first time we've provided free CPD units for participants. And while we can be satisfied with these firsts, know that in the coming years, we aim to improve the overall relevance, utility, and added value of the forum and our other knowledge dissemination efforts by improving the quality and variety of our offerings, expanding our collaborations both local and international, and providing more opportunities for closer interactions between researchers, policymakers, decision makers, and implementers. On a last note, we invite you to view our division's webpage on the Health Policy Development and Planning Bureau website, hpdpb.gov.ph, where you can access research reports implemented through our program, the DOH Medium-Term Research Agenda, our COVID-19 Local Evidence Database and meta-summaries, and our advisories that include calls for proposals and expressions of interest, and where you may also contribute to our evidence registries. Proceedings and other materials from this forum, as well as other resources and materials, will progressively be made available through our webpage. Again, thank you for participating in the 18th National Health Research Forum for Action, and we look forward to seeing and interacting with all of you in the next one.
Thank you very much, Dr. Gloria Nenita Velasco, or Doc May. So, we have come to the end of this session and actually also to the end of the 18th National Health Research Forum for Action. This 18th National Health Research Forum for Action had a theme of realizing universal health care amid a pandemic. And therefore, all of the session topics since the first session on the 8th of September was really all talking about COVID-19 and the various responses of the health system. Our session today, the fifth session in particular, had the theme COVID-19 Lessons and Ways Forward. And for those of you who were with us from the start of this session at 9 in the morning, I think it is not an exaggeration to say that we had a bountiful harvest this morning with the amount of information that we received from our various very learned and very experienced speakers and experts. And so we began first by receiving an update or at least a context shared by Dr. Ron Lau on our National Action Plan against COVID-19. And as Dr. Lau has pointed out, for sure there were challenges, or there are challenges, especially because the National Action Plan, even this third NAP or NAP, needs to really seriously look into how to balance reopening the economy with maintaining as best we can compliance to the minimum public health standards. And of course, the message of Dr. Lau is always a guarded optimism. In as much as Dr. Thea has affirmed that, in fact, our cases seem to be declining, we cannot yet relax. And Dr. Lau also reminded us of the six-pronged phase by which the National Action Plan was developed, traveling from a focus on prevention, to detection, to isolation, to treatment, to reintegration, and to mainstreaming in the new normal, for which the NAP3 is focused already towards mainstreaming to the new normal. And so with the many lessons that the NAP planning and implementation has given us, key takeaways include agility and adaptiveness of policies that must be rooted in science, communication as an important key, a whole of society approach is very much needed. Local government units are our frontliners and must be capacitated as best we can, and investing to build and sustain capacities in disaster management. Actually, what Dr. Lau gave us lessons are also similar to what we heard when Dr. Thea gave us an update on the work that has been put in to develop the COVID-19 surveillance and quick action unit and data management systems. So as I said, Dr. Thea showed us that indeed there is a slowdown, but there are also some seeming increases in areas that still require our close attention. We are continuously still facing the challenge that have to do with producing consistent and reliable data, and also the need to really capacitate local or front lines in terms of epidemiological and surveillance capacities. And so as our speakers have said, indeed, this COVID-19 has truly tested the preparedness and response plans of our health systems. Kumbaga, sa Tagalog pa, binigla tayo ng COVID-19 at lahat tayo na sorpresa at hindi natin akalain that 8-9 months into this pandemic, our movement is still restricted, and we also need to comply and make sure that we are following all of the minimum public health guidelines. And of course, what has been heightened here is with the devolution of our health system that's happened in 1991, we really need to strengthen, deepen, and enrich this relationship between the national government, represented, of course, by our DOH, with our local health system partners, represented by our LGUs and local chief executives, because they are at the front lines, because they're the ones who are out there toughing it out with the communities confronted with all of these. In as much as there have been many challenges and it has been quite difficult for all of us with COVID-19, I can say, and our speakers have pointed out, that there have also been many low-lying harvests. And very prominent among these is what Dr. Thea and even Dr. Ron has pointed out, is the acceleration of the track towards universal healthcare. If you recall, the Universal Healthcare Law was signed in February of 2019, and the implementing rules and regulations were signed in October of 2019. And we were really looking towards the gradual implementation of the UHC law this year. And then COVID happened. We did not put into the back burner the UHC implementation. It continues. But together with that, we needed to grapple with the challenges of COVID-19, as well as the different other disasters that have confronted our country over these past few weeks. And so with this, we realized that, in fact, this has been our testing ground, testing our capacities and capabilities towards UHC implementation in the areas of governance, in the areas of data management, data analytics, and what has been repeatedly mentioned by our speakers this morning, a whole of society approach, a multi-sectoral, multidisciplinary way of working and collaborating. And as Dr. Jihan has said, thinking out of the box, going out of our comfort zones, so that in fact our work is integrated, it's aligned, and it's consolidated. And we had two webinars for this session this morning. The first was our presentation on data. And this is through the presentation of the FASTER the faster method or the faster system for data management, data analytics that was presented, of course, by Dr. Estuar, for which, as Doc Eileen said, indeed truly complex, truly multifaceted. And Dr. Estuar reminds us that in as much as faster is important, it is rooted, data science is rooted on imperfect data. And therefore, it does the best it can with whatever data it is able to access, but it is far from perfect. What is important is that a mechanism like FASTER is able to generate as quickly, as timely, and as reliably as possible key data sets and analytics that will then help our decision makers and our policy makers make the necessary and appropriate decisions and guidelines. So actually, it's the FASTER's work that feeds into what we wait with bated breath at the end of the month or at the 15th of the month, when we had to wait for the decisions from the IATF and the President on whether we were moving out of ECQ to MECQ to GCQ, etc., etc. And so a multidisciplinary approach is important, but also a multi-agency approach that requires that we listen to the different people that we are serving as scientists, as researchers, as project and program implementers. We need to listen and to discuss with the people who will benefit from the data that is generated in a model like FASTER. And of course, this was also very much validated by Dr. Espina, who recognizes that we must bring all of this together and bring this all to bear to the communities and the people that we serve. And therefore, it is important not only to be as rigorous in the science, but also as rigorous in the way we translate this information to actually do what it is supposed to do, which is to guide our decision makers and also to educate and help our citizenry, the people out there in the communities, understand what all of these mean and how their behavior in terms of their health and the way they carry out their lives must be guided by all of these information. And of course, our second webinar, we listened to the story of how the clinical practice guidelines that are now guiding us in the management of COVID-19 were developed under the leadership, of course, of the Philippine Society of Microbiology and Infectious Diseases, and of course, together with its partner organizations, as well as the Health Professionals Alliance Against COVID-19. So the health professionals, the practitioners came together and come together, bringing to bear their knowledge, their expertise, scoring the world over for evidences to generate the guidelines to guide action, even to guide PhilHealth in how it will cost and pay for the benefit packages for COVID, as well as different policymakers and decision makers. Again, it is not perfect. It continues, as Dr. Isa says, it is a living CPG. And if it is living, we need to continue to sustain it. And sustaining it will mean that we need to be able to make sure that we are always on top of new developments. And this will require the necessary investments to make sure that there are enough warm bodies who will actually look at the data, make the modifications, and bring and keep on updating the so-called living clinical practice guidelines. And of course, the invaluable assistance of our Department of Health, who will make sure that all of these are cascaded, implemented, translated into guidelines, policies, memorandum circulars, so that these can all be brought all the way to the most far-flung areas, because of course it is the Department of Health who has the scale to be able to carry this out and relay all of these pieces of information to our stakeholders and to the different communities out there. And so at the end of all of these, what are some of the words that perhaps can be brought home as takeaways or memory hooks? First, of course, is the need for data and information. And together with this comes hand-in-glove research. And that is the whole point of the National Health Research Forum for Action. It is to highlight, to invest, and to emphasize that research is key. And research is not only to be able to expand the different resumes of our scientists and academicians and researchers. That's important, but more important is how to use the knowledge that is generated to be able to ensure the health and well-being and access to rational and quality care, especially in times of a pandemic where we need to move fast and be agile in our action. So research is key, data is important. The second take home, the whole of society approach, which means multi-sectoral, multidisciplinary. That means that we are all invited to get out of our worlds, enter into other worlds, collaborate with all of them, so that in fact the action is aligned, the action is quick and agile, and the action is truly responsive to the needs of the people. And this can actually really translate in advising our decision makers and policy makers. And so with that, I bring to a close this fifth session of the National Health Research Forum for Action 18th edition. And before I close, I would just like to extend or relay a few reminders from our organizers. First, if you encountered problems during the webinar, or you lost connection, or you did not finish the webinar, links to the webinar replay will be sent to your registered email address. Second, to receive a certificate of completion for this webinar, please take the quiz and answer the evaluation via the link, which will be sent to your registered email address a day after the session. Third, participants are only allowed to take the quiz once. You need to score 75 percentile or higher to receive a certificate of completion. Otherwise, you will receive a certificate of attendance. Fourth, if you only wish to receive a certificate of attendance, just go to the link that will be provided to you via email. Fifth, the webinar quiz will only be available for the next 48 hours after the links have been sent. Sixth, after the quiz is closed, your certificates will be issued at a later date after verification of scores. Seventh, as a final reminder, please double-check your email address during the registration. Incorrect email addresses will not receive related announcements. And so with that, I am now going to bring to a close this fifth session of the 18th National Health Research Forum for Action. We thank you very much for joining us today. For any questions and comments about the webinars or to reach the organizers, please email us at NHRAFA2020@gmail.com. For inquiries about registrations and certificates, please email us at the nhrfa.eturo@gmail.com. I'll repeat, nhrfa.eturo@gmail.com. And so in closing, I would like to personally extend my thanks to my partner for this discussion forum, Ms. Jane Arcera, who has very quickly and reliably relayed all of the questions from the chat box. I also would like to thank the invaluable assistance of my colleagues and friends from the Ateneo de Manila University's Institute of Philippine Culture, Dr. Dennis Batangan, and Mr. JP Dalupang, and the rest of the team from IPC Ituro. Also, special thanks to the very efficient and the very well-organized team from the HPDPB, led, of course, by Doc May and Renee Gasgonia and her team. Thank you very much. So here we're flashing Renee, Frances, Jane, and of course, our advisors for the 18th NHRFA, Yusek Mario Villaverde, Director Frances Mamaril, and Dr. Gloria Anita Velasco. Also, our PCHRD team, Dr. Ma'am Risa Reyes, Ana Itulid, Grace Senon, Mark Hasta, Mylene Marco, and as I mentioned, the team of Dr. Dennis Batangan, JP Dalupang, Marikit Mendoza, and Queen Tayam. So, with that, I am Dr. Maria Eufemia Yap, Senior Technical Advisor of ThinkWell, partner to the Department of Health, bringing this 18th National Health Research Forum for Action to a close. We thank you very much for joining us until the end of this forum. We hope to see you at the 19th National Health Research Forum for Action, hopefully again face-to-face or maybe blended face-to-face and online. Maraming salamat po. Magandang tanghali sa ating lahat.